Hi, good evening.
Good evening. Welcome, Rajanas Kashara.
Hi.
Hi.
Thank you. Very interesting topic, I think, today.
Yes, we will wait. All of the speakers, good presentations.
Yeah.
Hi, everybody.
Hi, Professor Konovalov. Thank you.
Hello.
Hi, Nikolai. Welcome.
Hello. How are you doing? Hello.
Good.
Is there any list of the names of the talks, or we just said the name and then we'll find the topic?
No. We have a line. Actually, first speaker will be Oscar, I think.
Yes. Yeah, I know. The name of the speakers, I know. I don't have the name of the talks. That's okay. So just.
The name of the talks are Oscar will talk on clinical and diagnostic challenges. Zan Chen will talk on anterior surgical techniques. Dr. Nobuyuki Shimokawa will talk on posterior surgical techniques, and Mehdi Darmol will talk on complication avoidance.
Excellent. And how long it will be? 1 hour or more?
Each speaker will talk 15 minutes.
Okay.
And at the end of all, we can have discussion. Or
So
it depends. After each speaker, we can get questions.
So it will be no longer than 1 hour and a half, yes?
Probably in 1.5 hours we will finish.
Okay, yeah, because I need to correct my schedule.
Yeah, right. Exactly. We have 6 more minutes and then we can start.
Okay.
No. Mehdi, welcome. How are you? Dear Mehdi.
How are you, Professor Zilali? Thank you.
Welcome.
Welcome. Thank you. Thank you very much.
Please unshare your screen because...
Okay. I shared my screen.
Okay. Thank you.
Okay.
Check.
Dr. Zanchen, welcome. How are you?
Hi.
How are you, Professor Zalagi?
Good to
Nice
see
to meet
you.
you.
And
Oscar, welcome.
Professor Oscar joined and Professor Kahraman joined, Sardar Kahraman.
Yes, we can.
Okay.
I think
Sardar,
that everybody,
welcome. How are you?
thank you very much.
Good to see you.
Good to see you too. I think we can wait for a couple of minutes.
Yes.
Okay.
Hi, it's Koto-san.
I want to say a few things. Actually, this is our 12th webinar on update of spine surgery. We are making every month such a webinar, and it's a very hot topic, management of OPLL. I will ask two moderators, Dr. Nikolai Konovalov and Dr. Serdar Kahraman, to invite speakers and moderate the session. Every speaker will have 15 minutes time, and after each speaker, we will get the answers to questions of the audience. Thank you all for joining us.
Oh, hello, everybody. Hi, we have to start, and the first speaker will be Oscar Olivas. He is here. Oscar?
Yes, sure.
Yeah, hi. So your
Hi.
talk is the first one. You can share the screen.
Sure.
So we'll have 15 minutes talk, yes?
Yeah, okay. Okay, so thank you for Mehmet, and for the invitation. You know, this is a joint session of MES, WFNS, and IAS, and my topic is the clinical challenges of OPLL management. I have no disclosures for this presentation. And I identify as a surgeon 5 clinical challenges. And the first one is to diagnose OPLL. It's an enthesopathy that involves thickening and calcification of the PLL, which is different from a calcified disc annulus. And this leads to reduction of the canal, spinal cord compression, and neurodeficits. I don't know about your practice, but my practice, currently, most patients are evaluated with MRI only. So you need a high suspicion rate for OPLL, otherwise you will miss OPLL. You know, this is the example of this case. If you do a CT scan, you find completely surprised and you see an OPLL compressing the spinal cord. You can see it also on radiographs. There is low inter-observer reliability. So the CT offers the most sensitive diagnostic tool. And on the sagittal sequences, you can classify the types of OPLL. For example, this case here, very narrow canal. With CT scan, you show that the problem is much wider. So it's crucial for the selection of the appropriate surgical technique, as in this case here. You have to prolong probably the surgery higher up, which was not the case seen on the MRI. What's the incidence? It's more common in older people, male to female ratio 2.1, more common in East Asians. The prevalence changes in Japan, Korea, but always above 3%, 4%, less in Europe and US. But I would like to stress that the incidence is depending on the imaging method. And this very nice study done in 1,500 health Japanese people, it could be identified in 3% of plain radiography, but 6.3% on cervical CT. And if you apply CT, you get a much higher incidence than the ones that are published. So, and you have to look also for ossification in other regions, like thoracic regions. So OPLL cannot longer be viewed as a vestigial thing or pathology in non-Asian cohorts. If you have spinal cord injury with OPLL, it's 23% on this paper, but 88% of those patients had no bone injury, and the fall was the most important mechanism. So, and of those that sustained a spinal cord injury, only 25% were aware of OPLL, and most of them, half of them already had gait disturbance before the injury. So the prevalence of OPLL among spinal cord injury is alarmingly high, especially in patients without bone injury. This epidemiological study, which is the largest one done, showed that symptomatic OPLL, the mean JAW was 9, which is already quite severe. And the most common for indication was a JAW of 11. And this is too late. As you see here from Michael Felling's group, MJAW less than 15, it's a clear indication for surgical intervention. But you have to diagnose it before, because the chances of getting a good outcome relates to the pre-op MJAW. Using this clinical awareness model, diagnostic model using machine learning method, patients with cervical OPLL had poor postoperative recovery. So they worked on finding ways to early detect cervical OPLL, to timely program surgery and have better results. And it seems that with age, we already know that, but body mass index were higher in OPLL. Main AST and urea also elevated, previous spine surgery, coronary heart disease, and if you see, anytime you see ossification of the anterior ligament, there is also higher chance of OPLL. But of course, with widespread use of CT, there is an increasing number of patients that you discover OPLL incidentally. So these patients, they don't need to be anxious. Most radiographically detectable cases are asymptomatic, and the proportion in this study of the occupants of canal was 27%. And surgery is advocated if you have more than 46%. And again, from this study, we should not be offering prophylactic surgery, but educate patients for relevant symptoms and signs of myelopathy. The second challenge is that OPLL per se is an independent risk factor. In this study here, with 1,500 patients, the overall incidence of complications was slightly superior to 20%. Neurological deficits, 8.3, CSF leak, axial pain, implant complication. So there is a high incidence of surgical complications in OPLL patients compared with other forms of myelopathy. So consider the risk of surgical complications when you communicate with patients for decision-making, and you should be alert for complications during and after the procedures. More operating time, more post-op drainage, CSF leakage, ischemia, reperfusion injury, also higher in OPLL patients. Dural tears, of course, high rate of CSF leak with OPLL surgeries, around slightly above 12%. which means you have dura ossification, that is the intimate adhesion of the dura to ossified PLL. On this meta-analysis, if you look at the C5 policy, significantly higher on OPLL, although the AO spine shows that there are equivocal results that are higher in OPLL, but not significant. It seems that axial neck pain is the most frequent complication after surgery, and this is probably related with the number of posterior procedures being done, higher rate of superficial surgical site infection in OPLL. But there are also papers like this one saying that there is no difference in demographics, in surgical approach, baseline myelopathy severity. The outcomes provided by surgery are the same, and the rate of neurological complications did not differ in OPLL patient versus all the others. So the third element is risk stratification among OPLL patients. Which one are the worst that we should be concerned? Appropriate classification is critical might be significant variations in neurological presentation, surgical outcomes, disease progression, and certain types of OPLL may be predictive of surgical complications. This is the Japanese Ministry of Health, Labor and Welfare classification. Basically have segmental, separate ossification behind the vertebral bodies. It can be early stage, but can be with very severe presentation, continuous type, mixed type, which is the common and usually severe, and localized, which is posterior to the disc space, and generally those are severe cases as well. You see one case of continuous, of segmental. Increased bone morphogenic protein expression was noted in continuous and mixed type. So they're probably also a pathological base on this radiological classification. It seems that myelopathic groups have more mixed and continuous, where asymptomatic patients more the segmental type. And mixed and continuous, they tend to produce a greater degree of canal stenosis. And risk of trauma-induced myelopathy also bigger in the mixed type. But there are many papers showing that this classification is not useful. There is no significant differences in upper or lower extremity function, urinary function. The pre-op jaws were similar. The type of OPLL is not predicting of progressive myelopathy. Very interesting are those continuous bridging OPLLs. You have to think that clinical myelopathy is a consequence of static and dynamic compression. And those patients with bridging OPLL, they have less motion, so they are less prone to myelopathy. Look at dural ossification. You have this isolated type, which is not related with OPLL, double layer, where there is some epidural space between the OPLL and the dural ossification, and the unblock, where all this is fused. And of course, the risk of injury is much higher with the unblock. And looking at double layer also, you have crescent type, short straight, long straight, and some authors claim that this can be related with the chance of developing myelopathy. Dural defects occur more prevalent with the non-segmental type. Of course, higher risk of CSF following anterior surgery, because it's technically difficult to separate the PLL from the dura. We should identify those high-risk patients, implement preventive measures, and even tell the patients that we might need to do techniques of dural repair. OPLL progression is a really big concern. More and more papers on the literature are reporting on that, which is by definition an increase in longitudinal extension of 2 millimeters on the thickness of 2 millimeters, or a new lesion, or bridging 2 or more existing lesions. And of course, this will cause further reduction of the canal. Involvement of C2, C3, C4 looks as a risk factor for progression of OPLL despite a laminoplasty. Also, younger patients and continuous type of OPLL are predictive of OPLL progression despite surgery. And on this very nice paper, if you look at different types of surgery, laminoplasty compared to laminectomy and fusion has much more progression of OPLL, and we should be aware of that and follow the patients. So concerning surgery, what's the time, what's the approach? This study with 480 patients, OPLL patients treated non-operatively, there was myelopathy progression in patients that were already myelopathic. So it means almost 50% of patients, but patients without myelopathy, only 16% progress into myelopathy. And Matsunaga already had shown that and predicted 71% myelopathy-free at 30 years old, 30 years follow-up. The canal stenosis is a more important risk factor for development of myelopathy, stenosis higher than 60 degrees. So again, prophylactic surgery is not recommended for patients without myelopathy. Conservative treatment is the situation. The risk of spinal cord injury is 0.2% per year. If you are a male, if you have OPLL and you are managed conservatively, there is an associated risk of a higher chance of spinal cord injury. With OPLL, 0.21% conservative treatment versus 0.37 for surgery. If you don't have OPLL, the risk is much lower. So surgery significantly lowers the risk of about 50% of myelopathy, progressive myelopathy in patients without OPLL. OPLL, this is the drama. Surgery via any approach is associated with higher rates of complications, surgical morbidity and reoperate rate. Patients with myelopathy are advised to undergo surgery, and despite the increased morbidity with the surgery, compared with non-OPLL cases, it's still better to operate them than conservative treatment for symptomatic patients. Decompressive surgery is standard of care for symptomatic, and the MJOA classification will help us to identify patients and select patients for surgery, MJOA less than 15. There is still a lack of consensus on timing and choice of surgical approach, and as we know, time is crucial. When you think about an approach in the setting of degenerative cervical myelopathy, OPLL itself is a modifier for selection of type of surgery. We have here an oxymoron, a paradox, which is the anterior approach, the one that tackles the compression. It's the most effective in terms of neurological improvement, but it's also the most risky, most associated with neuroinjury and dural tears. Posterior approach is lower complications, but a low disease progression. So this is the trade, and new surgical treatments can aim to reduce these complications, and I think the next speakers will approach this topic. As you see here, anterior approach is better post-op JOA and neurorecover laminoplasty, especially true if the space-occupying lesion more than 60% of the canal. The OPLL, the K-line is a very important concept, which is this straight line that connects the middle points of canal C2 and C7. The OPLL crosses the K-line, it's considered negative K-line. And generally speaking, patients with positive K-line, they tend to have a higher recovery rate and better postoperative JOAs. You can have a negative K-line because you have a kyphosis or you have a thick ossification, like on this case here. Patients with pre-op kyphotic alignment have better recovery with anterior approaches. Also, K-line negative, and this is a cohort of just patients with K-line negative, and they do much better with an anterior approach. With laminectomies, laminoplasties, you have a progressive loss of lordosis. And we are now looking at new data, new criteria for decision-making. And this very nice paper shows that high pre-op cervical SVA, there is high probability of sagittal imbalance and neurological symptoms with laminoplasty. So this is the kind of algorithm that I choose, less than 2 level anterior approach, more than 3 level. I will go posterior, looking at the space for the core, the occupation ratio, more than 60%, the K-line. If K-line is positive, no neck pain, laminoplasty, neck pain, fusion. If the K-line is negative with kyphosis, let's look at if it is flexible or not. And if not flexible, we need a 360 approach, or if it is flexible, we can go from the back. So just to show one of my cases, two level compression, high canal occupying ratio, not important. It's almost a straight spine, K-line negative, pre-op neck pain, and I did an anterior surgery. So what are the clinical challenges? OPLL is best diagnosed using CT imaging. but you need a high suspicion rate to prescribe a CTE. Like that, you avoid underdiagnosed or mistaken for milder forms of degenerative calcification, which is a different disease. OPLL is an independent risk factor for myelopathy progression and worse surgical results. That's why it's important to diagnose it. From the literature, there is still a lack of standardized and reliable classification system to stratify the patients and predict natural history management of OPLL outcomes related to the various interventions that we do. Thus, it's essential to identify patients at high risk of OPLL progression and implement appropriate preventive surgical strategies and regularly monitor those patients after surgery. And optimal time and approach of surgical intervention still controversial. Thank you.
Thank you very much, Oscar. It's a very interesting presentation, very important. Do I have special chat for the questions? I think we have a chat and all the participants can put their questions in the, and we will, I think we'll have a discussion after it because we need to listen, but you're just very correct that the most important thing in the treatment of OPLL is choosing of the approach to avoid the complications. And so I think we go to the next speaker. The next speaker will be Dr. Zhen Chen from China. Hello.
Hi.
Yes, you can continue, and then I think we'll try to we'll make the discussion at the end because I think we need to listen to all the data, and then we'll just see the most important, discuss most important topics. Thank you.
Okay, I have shown. I share my screen. Is it
Yes.
okay? Okay.
Yes, for sure.
Good evening, everyone. Because it's midnight in Beijing, and my topic is about ACAF for cervical OPLL. I'm Dr. Chen from.
Sorry, we don't see your slides.
Really?
There's a black screen.
Have the slide?
No, we cannot see your slides.
We cannot see your slides.
Sorry. I share it again.
We have black screen.
Zan, it says you have started screen sharing, but it doesn't start. Please unshare and then share again. Dear Zan, can you please share the screen now?
Yeah, I'm trying.
First you can stop your sharing and then you can start again.
Yes,
Okay.
we already stopped sharing. Now you can activate your screen. By the way, we have now more than 110 participants who join us.
Hi, is it okay?
Okay, we're all right. Yeah.
Oh, great. Thank you.
Yeah.
Sorry about that. My topic is ACAF for cervical OPLL. OPLL is very high incidence in East Asia area. So in our center, we have many kind of these cases, like this kind of cervical OPLL. And a new technique has reported in 2018. It's called ACAF. It's a kind of idea, a kind of technique that we enlarge the cervical spinal canal in the anterior approach and does not need to remove the OPLL lesion. So with this technique, we can reduce the incidence of CSF leak. And in China, we have performed a lot of studies on this technique, and we can see that if we perform a laminoplasty, the spinal cord have to shift backward to to away from the compression, anterior compression. So the spinal cord will change its normal shape. But when we perform ACAF, we enlarge the cervical spinal canal with anterior approach. The spinal cord can be decompressed just in situ, and the spinal cord does not need to move away. And so this will reduce the incidence of C5 palsy. And also, we know that if the K line is negative, when we perform post-approach laminoplasty, sometimes the result does not so good. But in the study, we found that if we perform ACAF, no matter the K line is positive or negative, we can get good result for the patient. And also, they have compared ACF and ACCF, and they found that the enlarged upper cervical spinal canal is much better, much effective with ACAF, and better than ACCF. And also, the doctors have compared ACF and laminoplasty, and they found that C5 palsy and axial pain is much more decreased significantly. But some dysphagia and hoarseness is increased because this is related with anterior approach. And so also the curve of the cervical spine is much better. Use anterior approach ACAF, and SVA is much is better with an anterior approach. And if the K line is negative, ACF will get a better result. And from 2019 to 23, we have performed 55 cases this technique for OPLL patient, and we have some very satisfied result. And but this technique is not difficult. So there in the beginning there did some have complications, and we have one case vertebral artery injury, and there is a CS leak in 3 cases, and there is 6 cases. So vertebral body does not left enough, and in one case we performed posterior decompression in addition. The most difficult part of this technique is how to cut open the vertebral body on bilateral side, because the OPL lesion is sometimes irregular, and sometimes the lesion is laterally. So sometimes when in the beginning, if we cut the vertebral body not so properly, and will cut open the OPL lesion, and it's very easy to lead to a CS leak. And also we should pay attention to vertebral artery, because a lot of this kind of patient, the vertebral artery have some abnormal running. So before operation, we have to check CT angiography to evaluate the vertebral artery. And I have shown some cases. My first case is a male, 58 years old. He has performed laminoplasty 8 years ago, but he still have a lot of symptoms. And on X-ray, we can show that he has performed laminoplasty, and but CT scan showed the OPL lesion is very huge, and the spinal cord is still be compressed in the anterior side. So I do the operation, and I published my first case of video. And this is how we do the operation. First, we do ACDF for every level from C3 to C7. But in the levels that there's a OPL, we do not need to remove the ligaments totally. We just remove the disc. And then we cut open the vertebral body on bilateral side with a bone with a burr. You can see the vertebral body are cut totally open. And then we plant a plate, and with the and then cut the vertebral body on right side. And then we can use the screw to pull the vertebral body upward and decompress the spinal cord. And this is on the journal we published this video to explain how to do the operation. And before operation, we can see the spinal canal is stenosis, but after operation, the spinal cord is the cervical spinal canal is enlarged, and the spinal cord is decompressed much better. And the second case is also male suffered a very huge OPL lesion. MRI showed the spinal cord is compressed. He has performed post decompression and fusion technique. And after decompression, we can see though the spinal canal is enlarged, but the spinal cord is still compressed on the anterior side, so the patient still have symptoms. And we performed the ACCF for this patient for revision. And after surgery, we can see we can totally enlarge the cervical spinal canal. And after operation, we can see this spinal cord is totally decompressed. And the patient symptoms can get much better. And this is before operation, after the first post decompression operation, and this is second anterior decompression operation. And this is how the spinal cord decompression is changed. We can see after the first operation, the spinal cord, the anterior side is still have some compression, but after ACF, the compression is totally relieved. And the third case is a 37 years old male. He suffered weakness in 4 extremities for 6 months, and MRI showed very severe decompression of the spinal cord, and CT scan showed the OPL lesion. And we performed the 3 level ACAF for this patient. The spinal cord is decompressed. And this first case is the most severe case in my case series. It's a female, 49 years old, before operation. 1 day before operation, he suffered suddenly paralyzed in 4 extremities, and his lower extremities muscle strength is 1 grade. And the CT scan showed a very large OPL lesion from C3 to C7. And this is X view showed the OPL lesion. And the MRI showed the spinal cord are decompressed severely. And this is X view of the cervical spinal canal. And I performed ACF emergently for this patient. And the operation lasted for 10 hours. And but it successfully decompressed the cervical spinal canal, the spinal cord. And MRI showed the spinal cord is decompressed. And 3 months later, the female patient have no neurological symptoms left. And this is another patient, 52 years old. He suffered lower weakness of lower extremities for 5 months. And on admission, his left muscle strength is decreased, especially the lower extremities is decreased to 1 grade. And MRI showed a very severe compression of the spinal cord. CT scan showed a very large OPL lesion. And we do operation emergently for this patient, and 3-level ACAF. And after operation, the spinal cord is decompressed, and the patient symptoms relieved at the 2nd day after operation. And another very special case is a male, 79 years old. He has performed ACDF 25 years ago and laminectomy 10 years ago, but his symptoms is severe, still very severe. And this is X-ray showed he has performed ACDF 25 years ago. He used a special cage. And so he has also performed laminar posterior decompression, but the spinal cord is still compressed. X-view showed the how severe of the spinal cord is compressed. And CT angiography showed the anterior body was totally fusioned together of the 3 level. And the CT scan showed on the posterior border is OPL lesion. And we found the cage is laterally to very close to vertebral artery on one side. Very close, only 3 millimeter near to the vertebral artery. So we performed the ACCF for the patient. We pull up the 3 vertebral bodies to save the time we escape the video. And after operation, we successfully pull up the 3 vertebral body anteriorly. And you can see after operation, the spinal canal is enlarged. We compare anterior and posterior operation. And the spinal cord is totally decompressed. And also, we progressed this technique to Kolosky technique. That means we can more carefully design how we perform this technique, and then use the more carefully planned technique. We can reduce the furin levels, and that means for this patient, if we perform ordinary ACF, we have to pull up C3, C4, C5, and also C6, 4 level. But with more better planned of the technique, we only pull up 2 level, and the furin the 4 level, we can totally decompress the spinal cord. And this is a very special case, 66 male patient. On MRI showed a very severe compression of the cervical, on the cervical spine, and X-ray showed the spinal cord is compressed. And this C7, and the CT scan showed a very multi-level of OPL lesion. And on the CT angiography showed a lot of bone hydrate on the anterior border of the cervical spine, and it's very dangerous to perform ACF at C4 level, because the vertebrae running is very it's running irregularly. It's very easy to hurt the vertebrae at here. So we do a very carefully planned technique. We just pull up C3 and decompress the cervical spinal cord. And this is the video of our patient. And to save time, I'll skip it. And this is after operation. You can see we just pull C3 upward and to decompress the spinal cord. And this is how we perform the operation. We just pull up C3. And the spinal cord is decompressed successfully. And because with the anterior procedure, the patient recovered very quick. On the third day, he can be discharged. And we write a chapter on this book of ACF to describe this technique. And now we're running a randomized study to compare ACF and laminoplasty for some cases, which especially with the cases the K-line is negative. And to finish my lecture, I would like to say that ACF is a very powerful technique for cervical OPL, and microsurgery is very helpful for the technique. Thank you.
Thank you very much for a very interesting presentation and a really excellent technique. Very modern. Thank you very much. I think we have more questions at the end. And so we go to the next speaker because we're a little bit out of time. Professor Nobuki Shimakawa from Japan. Please connect. You can share your screen. And we have already some questions in our chat, and we'll just ask all the participants them later. Thank you very much.
Can you hear me? Can you see
Yes,
me?
we hear you. We hear you. Yes, you can start your presentation. Thank you.
Okay. Okay. My topic is a posterior surgical technique. This is a photo. I was a member of WS Spine Committee from 2013 to 2008. This is a memorial photo in Russia. In
Can you
2021,
please make it whole page? We see.
Yes. Press, please. Yes,
Yeah.
play the presentation.
what?
The slides are not moving. You will see only all the slides together.
All
Okay.
slides together.
Please click the whole page button on the right bottom place. Whole page.
Bottom.
Full, you can select the button, full presentation button.
Good.
It's okay. You can see?
No.
No.
Yes,
Now
it's
it's okay.
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 Yeah.
No.
Okay.
Thank you.
Hey. Surgical indication for cervical OPLL. There is no evidence to recommend preventative or surgery for asymptomatic or mild cases. A good indication is a progressive type, including rapidly or slowly. A relative surgical indication type is a large OPLL type and combined canal stenosis. This is K-line, as you know. K-line plus is a good indication for laminoplasty. In 2020, this paper shows surgical decision-making for cervical OPLL. Anterior approach is a K-line minus OPLL, and K-line plus and large OPLL. Posterior approach, K-line plus OPLL, and small type OPLL, and multi-level combined pathology, more than 3 levels. This is my case, is a CSM case. Posterior decompression, and 3 years after, the kyphotic changes occurs, and the patient deteriorated. But point of the kyphotic change of after laminoplasty is a chronic compression of ventral region of spinal cord. It means a compression of the anterior or spinal arteries. So decreased blood supply is related to the denervations. Among spinal surgeons in the 2010s, attention began to be paid to T1 slope and post-laminoplasty kyphosis in CSM cases. Like this paper, more than 25-degree T1 slope. In this paper, more than 26.5 degrees. In this paper, more than 29 degree of T1 slope. And this paper has a strong correlation among the T1 slope and C27 SVA. And operative not only T1 slope, but also T1 slope minus cervical lordosis and cervical lordosis per T1 slope in CSM. This is T1 slope. This is a C27 angle. So cervical lordosis per T1 slope, it indicates the tilt. And in this area is a good coordination. And 2022 from Japan, about the cervical OPLL, the SVA was also focused. This is vertical line. This is C7 posterior cranial point. And this distance A indicates the CSVA. So this paper was a retrospective studies. Anterior decompression fixation case is a 28. PDF means a posterior decompression fixation and laminoplasty. All laminoplasty cases were belong to K-line plus cases. High SVA group and laminoplasty group shows the postoperatively kyphotic change. Again, high SVA and laminoplasty group shows the kyphotic change and related to the lower recovery rate. In these cases, shows all mixed type OPLL, large SVA, and elderly patient. This manuscript concluded these patients should be went the not only posterior decompression but also posterior fixations. In 2016, in these papers, PDF should be recommended for large SVA cases. Here's Sakai in 2016. He proposed a K-line tilt. K-line tilt. This line is a vertical line, and this is a K-line, and this angle named K-line tilt. In 2023, Sakai proposed the K-line tilt is a predictor of postoperative kyphotic change after laminoplasty for OPLL. Kyphotic change group shows the high K-line tilt and large SVA and large C7 slope and lower recovery rate. So the author concluded K-line tilt more than 20 degrees was a risk factor of postoperative kyphotic change after laminoplasty for K-line plus OPLL. In 2019, Dr. Bajiri reported the review about the OPLL progression after laminoplasty. More than 50% cases has the OPLL progression after laminoplasty. This is a Chiba paper. Chiba, as you know, is a student of Hirabayashi Keio University. They emphasize that cervical OPLL expands in the early period after laminoplasty. This indicates a strong relationship between motion stress and OPLL progressions. PDF. In 2016, from Japan, they calculate the volume of OPLL, compare the laminoplasty group and the PDF group. Result, left side is a PDF group. Right side is a laminoplasty only group. You can see the suppression effect of PDF, of progression of OPLL. This is my case. K-line minus and B-cut type OPLL. 68-year-old man suffering from a progressive motor weakness. The patient had a not so bad whole spinal sagittal alignment. So the patient underwent kyphotic posterior or decompressive fixation surgery using pedicoscope. I left the anterior or large space for future additional anterior approach to the OPLL. Fortunately, the patient improved 1 year after and 5 years after. CT scan showing the this is a big portion of the OPLL. 5 years after, the CT scan shows the flattening of the surface of the OPLL. Like that. Division surgery for OPLL. In 2024, from Korea, in this case, big type mobile segment, the patient underwent just posterior decompression. But 2 years after initial operations, the patient deteriorated. That's why the patient underwent anterior decompression directories. In these papers, the authors divided second operation plus group and minus group. Plus group showed the range of motion, large range of motion of OPL or level. So the authors emphasize mobile segment and big OPL are risk factor. In 2007, this is my case, 42-year-old man suffering from progressive motor weakness. You can see the small OPL and the combined protruded disc hernia like this, C5-6 level. The patient underwent the partial vertebrotomy and grafted bone and fixed cylindrical cage corner to corner, named Homer method. Just post-operative radiograph and MRI showing a good position of the under decompressions like this. During 2 years after operation, the patient good recovery, but the patient complained of neck pain and neurologically shows the C5 palsy of the right side. At that time, dynamic X-ray, you can see the minor instability at C4-5 and subsidence change of the iliac bone grafting portions and non-unions. Right side VA spontaneously occluded. It may be due to arteriosclerotic change of the severe diabetes mellitus. So I selected the posterior cervical fixation using the pedicle screw right side of the occluded side, and the lateral mass screw is the left side, patent VS side, and the posterior decompression of the foraminotomy of C5 nerve root. After the operation, the patient's neck pain disappears, and C5 pulse improved. 5 years after, good bony infusion obtained, like this. Progression ratio of cervical OPLL. This is my case. During 70 years, cranial directions 1.2 millimeter per year. Caudal direction 0.3 millimeter per year. Thickness 0.3 meter per year. Don't forget, OPLL is a progressive disease. In conclusion, currently, when performing posterior decompression surgery for cervical OPLL, the pre-operative radiological evaluation should focus on SVA, mobile segment, and K-line tilt. After posterior surgery, attention should be paid to kyphotic change, OPLL progression, and mobile segment. Thank you for your attention.
Yeah, thank you. And ask my moderator to continue.
Professor
Okay. Okay. Now we can start the discussion. If you have any question.
We have one more talk, I think, no?
Okay.
There is one more talk, Serdar.
One more talk, yes.
Dr. Mehdi Darmul.
Okay,
Yes.
we can continue with the new talk, Dr. Mehdi Darmani, and then we can start the discussion after the whole talks.
Okay. I will share my screen.
Okay.
Hello, thank you very much, Mehmet, for inviting me on this very important symposium. And I think the previous speaker, they have given a tremendous amount of knowledge and insight into the OPLL and the related issues. My question is with Oscar, do you have any dural tear or dural damage when you go for anterior side? You just remove the OPLL. OPLL is very densely adherent to the dural, and or you just thin it out and let it float off from the sac.
Please, you can activate the.
Thank you for the question, Tariq. No, I do not advise to remove the OPLL. I think what I do is the anterior floating technique, where with the drill, with microscope, you just thin as much as you can, and then you release on the sides, and then you see the expansion of the dura.
Yes.
I find the Zen technique very elegant, very difficult, but I'm afraid of doing it when you pull everything on a block and you don't see what you are pulling. You don't have a direct control of the situation.
And now,
so I'm much more confident in my technique with the anterior floating technique, which is, if you are a trained surgeon using a drill, you can do a very good job of decompression without risking CSF leak.
okay, now we can continue the next talk, and then we can have questions from the participants. Please share your screen, Dr.
Okay, thank you.
Okay.
We'll carry on discussion later on. Thank you.
Thank you.
Okay.
Mehdi, can you share the screen?
Unmute yourself, Dr. Mahdi, please.
I cannot. You cannot activate. It's not activated. I don't know how to activate.
Now repeat
Should
again.
be activated by the. Okay.
No, you can.
No.
Yes,
Good.
we
It's
can
okay
see.
now.
Yes.
You can
Is
click the full
activated?
presentation. Yeah,
Okay.
yeah, okay. Okay, yes, we can see
I
it.
can start.
Yes,
Dear
sure.
moderator, dear colleague, I will talk about complication avoidance in the management of cervical OPLL. OPLL is an inflammatory process resulting in the replacement of the PLL with lamellar bone. This leads to reduce the spinal canal and then to the compression of the spinal cord, which can contribute to degenerative cervical myelopathy. The prevalence of PLL is higher in Asian and range from 0.1 to 1.7 in American and European, and very, very rare in our country in North Africa. The diagnosis is made by radiological assessment, especially with CT scan, plain radiograph, and MRI. Only symptomatic patient, moderate and severe.
We cannot hear you.
I'm afraid his connection was lost. He has trouble.
Okay. We can wait for a while, and then maybe we can connect again.
Maybe we can take a question, and I will call the Professor Mahdi by phone.
Okay, it could be. Now we have a time to wait the Dr. Mehdi, and then we can have questions from the participants. Okay.
We continue with the question.
Yes. Anyone has a question?
I have a questions from the chat. I can read them. So the first question was about repairing dura. If you have dura trauma during the anterior approach, how you can do this. So this is to all the talkers. So this is from the chat. all the lectures can answer it. Oscar, if you have the dural damage, what are you going to do?
The first thing to know is a dural tear in anterior cervical spine is not as bad as a dural tear in lumbar spine, okay? The flow of CSF is much smaller. So normally what I do is just use some sort of patch and glue, and most of the time will go away. Of course, if it is a high flow fistula, you would supplement with a lumbar drainage for some days and watch how it goes. But generally, it's not as complicated, as difficult to manage as and anterior repair. It's not easy, especially in the setting of OPLL. It's quite complicated. But that's my general approach.
Okay. So we have another question from the chat. What the rate of recurrent of OPLL? Rate of recurrent.
I think with anterior techniques, the ones that tackle the OPLL, anterior floating or Zen technique, the recurrence rate is really, really small. Whereas if you go posterior, if you do a laminectomy alone, that's the worst scenario. It can be almost 2/3 of the patient. If you do a laminoplasty, almost half of the patients, the OPLL will grow. And if you do a fusion, that's the best scenario, around 30% of regrowth of the OPLL. These are general numbers.
Yes. And
I think Nobuyuki can answer that question better. And he paid attention that it is a progressive disease. If you leave the OPLL, it progresses. We know it well. What is the recurrence rate, Nobuyuki? What do you think?
Thank you. And the progression of the OPLL is a much important issue for the patient and the surgeons. Just posterior decompression is indirect decompression. That's why I should take the multi selection and technique we surgery should have, and depend on the cases and the level of the OPLL, we should select the selection of the approach.
Okay. We have one more question from the chat. The question is about Artur Goel technique, that he recommends only fusion during the OPLL. What is your, and he thinks that the compression is not necessary. What do you think about it?
I think the best guy to answer this question is Mehmet. I heard Mehmet giving a wonderful lecture on the topic in front of Atul in India. So Mehmet, please.
This is a good. Actually, Atul was with us. Are you here, Atul?
Yes,
Atul
I'm
has
here.
connected.
Oh, great.
Hi, how are you? The question is for you. Actually, one of the participants is asking the value of only fixation. Would you like to say something?
No, as you know, I'm absolutely convinced. I have no doubt. And I'm talking now on the basis of a very big experience that there is no need to do a very extensive decompression or any kind of decompression. Only fixation is the treatment, and magic is the clinical result. It has to be just seen and believed. It is not, when we see images, when we see the MRI, we see the huge compression and cord getting compressed, and it is, nobody can believe that such compression you don't have to decompress. But you just do fixation without any kind of decompression from front or from behind. Mehmet, as you know, I have been talking about this for a long time now. I'm sure, I'm convinced that this is the future of the treatment.
Okay. My comment on this issue is I have explained in Atul's meeting in Mumbai. Yes, fixation helps to stop the progression of OPLL. Because of that, I prefer laminectomy plus fusion surgery. Because of that, especially in the younger patients, because the progression of the OPLL is a very long duration process. The second thing, making no decompression and only fixation is not very well validated yet. Actually, although Atul presents very nice results, we need comparative studies, multi-center studies to learn the outcomes of those patients. This is my response.
Thank you. I have the question to all the participants also. What do you think of role of neuromonitoring during this procedure? Somebody use neuromonitoring?
Yeah, actually, I do sometimes, but we also did a very detailed study on the value of monitoring in cervical myelopathy patients, and we found that it's very valuable in cases to prevent C5 nerve palsy.
Yes.
Especially EMG monitoring of the deltoid muscle. But we did not find very significant differences if we monitor MEPs of lower extremities or SEPs of lower and upper extremities. We did not find significant differences in outcomes in monitored patients and non-monitored patients.
Thank you. Any more questions? Somebody want to ask more questions?
So Nicola, I wanted to ask to do Zen chain, and he has very nice technique, anterior techniques. And I wonder about micro decompressions. And sometimes we make corpectomy under 2 levels if there is a OPLL, but he make a lot of levels with anterior and only micro decompressions. And Professor Zan, do you compare with micro decompression and corpectomy? What is the differences for results?
Excuse me. You mean ACF and ACCF between the difference?
No, I want to know about you make multi-level microdiscectomy with anterior level. In this cases, we select sometimes posterior approach for with laminoplasty or laminectomy, but you made 3-level, 4-level with anterior and for microdiscectomy. And I think it is useful again because you use these techniques. And I wonder about differences when you select posterior and anterior multi-levels, and how's your results for all of the anterior when you compare posterior approach?
Yeah, I understand. And in the beginning, when we begin this technique, we use the technique to treat most of cases of patient, whether the K-line is positive or negative. And I found that most patients can get a much better result than posterior approach because the axial pain is we worry about the posterior approach. And in the anterior approach, it's minimal invasive though we fusioned several levels, but the approach is minimal invasive. The patient recovered very quick after operation. But until approach, we will need cost more time and more surgery times. So sometimes after several years later, if the K line is positive, now I would like to perform post-approach laminoplasty but much better. And if the K line is negative, then we choose anterior approach ACF to treat the patient.
Thank you.
There's one more question. I see the raising hand also.
Yeah, Jalal Najar.
Yeah, good evening, and thank you all for your kind presentation and great information. My question is, if half of the cases will be deteriorated by observation, why we did not recommend surgery for asymptomatic patients? The second question, if we do a posterior approach for laminectomy and plus fixation, we should make our screws and fixation before do our laminectomy, as I understand. And thank you all. Is my question clear?
Yes, I think Dr. Zileli can answer this question. Dr. Zileli, do you think that
I'm not the speaker, actually. The question goes to the speakers.
But you suggest that the laminoplasty and the fusion could be together to prevent the progression of the OPLL?
Yeah.
So that's why the participants asked this question.
Oscar, what would you say?
I can add, starting from the last question, which is a technical question. What I normally do on laminectomy and fusion, I remove the spinous process, and this gives me the possibility to do medial angulation, lateral angulation of the lateral mass screws, which is the next step. And after the construct is done, I do the laminectomy. So that's the sequence of my surgery. And the first question.
By high-speed drill, not by Carrison, of course.
No Carrison, drill all the time. You thin it as much as you can, and then you just leave a thin shell of bone, and then with a 2mm Carrison, you take it out. And it comes as an unblocked lamina. And the first question, sorry, was?
Was it in why we did not recommend prophylactic surgery for the patient with severe stenosis had no symptoms, as half of the cases will be deteriorated by time.
Right. So as I showed on that epidemiological study, the current situation is most of the patients are offered an operation very late. The mean JOA was 11. And for surgery, and the mean JOA of those patients on that cohort was 9, which is too late. So we need to make an effort to operate those patients. But on the other hand, it doesn't mean we should operate everybody. And we know that most of the patients have stable OPLLs. And if they are asymptomatic, it's nice to give them advice so they can look at symptoms themselves, schedule visits, once in a while, repeat an imaging. And I don't think you should operate on asymptomatic patients, truly asymptomatic patients, even though we know that there is a little bit higher risk of spinal cord injury in OPLL patients. I think if you educate them, it's quite reasonable to do instead of prophylactic surgeries. That's my understanding and what I found from the literature.
Yes. The patients with mild symptoms or without any symptoms can be just advised not to have a major trauma, but otherwise just follow up. So there is a conservative management the sentence, but it's not very well understood what is conservative management in those cases. But just follow the patients without any symptoms with severe stenosis. Even there is a T2 hyperintensity, you can make it. But by the time if a radiculopathy happens, like a arm pain only, then we must recommend surgery.
I agree. Same. More questions?
Yes, my question about the reperfusion injury. So anyone has a experience about the duroplasty after the compression?
Well, Cedar, you know, there are many myths in spine surgery, like in brain surgery, and I think this is one of them. You know, I could not identify a single case where I had this problem. And, you know, all the complications or the neuro complications that I had in the past, I could identify what was the problem, what was the technical problem, the bad maneuver that I did during the operation. So I'm not sure this is one of those topics that we know it, that exists from lab, from animal work, but I'm not sure this is as prevalent as it is described in papers, especially in older papers. I think most of those situations are kind of situations where your technique was not 100% reliable. That's my understanding.
Okay, thank you very much. I think that the Dr. Mehdi come back and then we can continue for the Dr. Mehdi, can you hear me?
But the laptop, the electricity and the internet in my home not working now. Suddenly, I don't know. If I can do this by my phone, but without screen.
Okay. So then I think that it's not possible without screen.
It's not possible? Yes.
I don't know, Dr. Zileli, what do you say about that?
Yeah, he can try to share the screen. If he can, it's fine.
No, I am in my phone. I haven't the presentation.
Sorry. Sorry,
He can
it is
show
impossible then.
Without a screen, I can't do it.
Sorry.
No.
Okay.
Yes.
Screen. I have suddenly, I don't know. Suddenly, all the electricity in my home dropped. If I can sharing like this, no.
This is better. We don't do it. Thank you.
Okay.
Thank you, Mehdi.
Okay. Thank you.
Nikolai and Serdar, you can comment on the whole topics and then we can finish.
I think it was wonderful presentations. Were very interesting for me. For example, the technique for anterior decompression was very interesting. I think I will going to use it in the future. And I want to thank you all the participants, all the lectures. It was really very interesting topics we covered. And I want my co-moderator to finish, please.
Yes. We together thanks to all authors and all presenters and also all participants. I think that the cervical myelopathy still has some controversies regarding the surgeries in terms of the posterior anterior approaches regarding the clinical results. So that's why still we will discuss the results of the techniques in the future. Thank you.
Thank you,
Thank you all the participants for being with us. Goodbye.
Thank you.
Thank you.
Take care.
Thank you all.
See you soon.